Another thing that I want to mention that I'm excited about both of our podium presentations. So if you all have heard of our educational projects, a lot of times we use the evaluation framework of Kirkpatrick's evaluation framework. So there are 4 levels. There's one level of evaluation that's just sort of the smiley scale. You know, did you like it? Did you feel comfortable? Did you like the food? How was the temperature of the room? Second level is knowledge change. Did their knowledge improve as a result of the intervention? Third is behavior. Did their behaviors actually change? Are they doing something different? And the 4th level actually is the Holy Grail. Okay, in medical education, it is the Holy Grail to have some sort of patient tie-in, to show some sort of impact. And both of today's presentations tie into patient care, which is really outstanding. And a lot of our projects through HERS did tie into patient care. Not to say that's the only place to go for education research, because there's a lot of interesting things to find out. But when you can hit that level 4, it's really exciting, and that gets the attention of the journals, and that's when you start to really get a lot of attention for publication. So, if you all remember, back in August, I think, we sent out a call for abstracts for Teach Education Day. The products of which are displayed out in the hallway. All of those individuals, so there are 22 posters on display out in the hallway. So all of these individuals, at least 22 individuals, but they're all done with teams, are doing something really cool and innovative related to education, related to teaching. That's really, there's a lot to be said about that. So out of all of those abstracts that were submitted, we chose one for a podium presentation, and it really showed outcomes, and it was very valuable. Dr. Sherry Hartman is our selected podium presenter out of all of the abstracts that were submitted, and she talks about a really neat program, SBIRT, that really identifies and teaches learners how to identify and treat substance abuse issues. So if you don't mind coming up, Dr. Hartman.
Thank you. This is an amazing honor to get to be here today. I don't think you'll find in my presentation the challenge of speaking too quickly, but I grew up in South America, so I don't know. There's a whole different timeline that goes on down south of the border. I think I was talking to Dr. Valea about that earlier. My challenge will be keeping within the 10 minutes that I'm allotted to cover this topic with you, because once I get on a roll about SBIRT, I mean, at a party, don't bring up this topic. You won't get away from me, because I am truly so passionate about training our students in SBIRT. So I hope that you'll come away with some understanding about the reason why I have so much passion about this topic. Let's see if I can get technology working here. So SBIRT does stand for Screening, Brief Intervention, and Referral to Treatment. This was a team effort, as Sherry mentioned. I couldn't have done this without the folks that are listed on this slide and a number of folks who are not listed on this slide. When we applied for the grant that funded this training project, we had to go to Dr. Don Keyes and get his blessing on being able to do this training program in 6 different departments. So his name isn't here, but he was a key supporter of this work. And then there's a number of you. Dr. Chris has done work in SBIRT training and implementation as well. A lot of folks really represent the reason why this could be successful. So I got to work with, I'm in the Department of Psychiatry, and actually every day I get to work with this young man here, Dr. David Hartman, was a co-investigator, and also these folks helped in the training itself of SBIRT. I also got to work with Jeff Wilson, Dr. Jeff Wilson, Dr. Rick Seidel, Dr. Bill Ray, and we partnered with a number of institutions, which made it a really rich experience. We got to partner with the Jefferson College of Health Sciences. We worked with the School of Nursing there and also with Radford University School of Nursing. A key leader in the project was Dr. Nancy Brossois at Virginia Tech. This was funded by SAMHSA funds. SAMHSA stands for Substance Abuse Mental Health Services Administration. It's a division of the Department of Health and Human Services. I applied for the grant several times, and persistence sometimes pays off, and we got it finally, working collaboratively with Nancy Brossois. So this was a training grant that we received in 2015. What SAMHSA did early in the century is they began issuing replication grants to try to encourage practitioners throughout the country to replicate SBIRT best practices. Because of the evidence that they got regarding its effectiveness, they then rolled out training grants, and that's what I applied for, was one of the SBIRT training grants. So it is evidence-based for identifying and reducing problematic use and abuse of alcohol, medications, and illicit drugs. The summary of their research was published by SAMHSA in 2011. But the seminal work in this field actually was an emergency department physician. You might recognize the name Gail D'Onofrio. She is at Yale University and did research that dates back into the 1990s, demonstrating SBIRT's impact on reducing problematic alcohol use, resulting in fewer return visits to the ED, and also reduced subsequent hospital utilizations. They focused primarily at that time on alcohol use. The findings were so compelling in terms of the cost effectiveness of this methodology that SAMHSA invested a considerable amount of money in the replication and dissemination of this methodology. All right, move on. So what is SBIRT? The S in SBIRT stands for screenings. So that's part of the training that you do, is you train your healthcare providers in using standardized screening tools. And they're very simple tools, they're strictly screening tools. Their concept is that you would universally use these pre-screening tools with everyone. We like to say, even with your grandma, everyone needs to be screened. You can't tell by just, eyeballing somebody whether or not they have a substance use disorder. So that's part of the push of this SBIRT methodology, is that you would engage in universal pre-screening, and it can be a very, very simple, short pre-screen. What they find is that in the typical practice, about 25% are likely to pre-screen positive. And then you go from the pre-screen to your full screens. These are, again, standardized measures with good data about their validity, ranging from the audit, which is an alcohol use disorder identification tool, to the DAST, which is about drug use. The CRAFT is what you use with teenagers, if anybody here works with the adolescents, and the 5 Ps with the pregnant populations. And we've actually, because of Dr. Chris's leadership, have been able to embed these screens actually into EPIC so that they would be at the fingertips of our healthcare providing teams here. The BI in SBIRT stands for brief interventions. I always talk about doing the BI as kind of a dance that you learn to do. This is an application of motivational interviewing skills to tap into a person's own reasons for change. It facilitates readiness for change, and you engage in a negotiation to come up with a plan for change collaboratively with your patients. The RT part of SBIRT stands for referral to treatment. And actually today there's more and more emphasis on the RT part of it. Some of the studies that are done nationally found that about 8% of our population nationally has a substance use disorder, but only 10% get into treatment. So one of the major goals that SAMHSA had was to try to impact that and get more persons in need of treatment into treatment. Anybody have a little bit of water? My mouth is going dry. So we spend a lot of time actually on training motivational interviewing. We actually have one of our trainees right here. Ellie Romani was in it in our Department of Psychiatry. So we do training on motivational interviewing core principles and skill development. That includes non-judgmental acceptance, compassionate collaboration with the patient. You use a brief intervention that includes engaging the patient, establishing rapport with them. You achieve focus in your interaction on the behavioral change that you're interested in, and then you facilitate readiness to change by working with the patient. Again, like I said, tapping into their own reasons for change, and then collaborating with the patient to negotiate the change. The skills that we work on are using open-ended questions, affirmations, reflective listening, and summarizing, or what they call the ORS strategies. Thank you very much. I love this approach for working with patients that might have problematic substance use. It's really a significant shift from, the traditional way, the old way of working with patients with a substance use disorder was confrontational. And you had the idea, it was the premise, that a patient had to hit rock bottom before they would be willing to change. So what SBIRT does is it builds in motivational interviewing into its methodology. And I always, as we teach this, I base the teaching on the premise that you don't have to be a psychiatrist or a psychologist to be good at motivational interviewing. This is something within everyone's skill set that we can do. And it's fun to watch Gail D'Onofrio do this. She is a very fast-talking and very decisive ER doctor. And when you watch her use this, it's very exciting because even in a short period of time, she can get that patient to open up and answer questions and probably get at honest answers faster because she's using these kinds of motivational interviewing tools. So it doesn't actually take longer necessarily to use this methodology. So that is really at the heart of SBIRT, is motivational interviewing. A lot of emphasis gets placed on screening tools, which is very important. But what people fail to realize is the bulk of the training is really focused on motivational interviewing. So we got to do this kind of training throughout 6 departments at Carilion, as well as with undergraduate students. At the undergraduate nursing level, we got to work with master level students in the counseling department, as well as with our medical residents in these 6 different areas. One of our goals of the training was to identify the factors that influence the successful implementation of the SBIRT training. So throughout this 3-year period, our goal was to reach 400 students. We actually were able to reach 852 because there were so many nursing students who we were able to reach with this training program. So that was exciting. We were a part of this national project, so we used the tools that were produced by SAMHSA. It included, Ellie may remember, it included this 5-hour online training that was designed to standardize the training and also to be flexible so that you could engage in the didactic piece sort of at your own time on your own schedule. So it had that, and then it also had a face-to-face workshop. And that's where we really focused on the role-playing and the development of motivational interviewing skills. And then that was followed up with supervised practice in the classroom, in the clinical settings. David, that's part of what he would do, is as he had residents rotate through ambulatory psychiatry, they would practice SBIRT skills in the clinical setting. And then there were also clinical simulation labs that were used. The core training spanned from 1 half-day session plus these online modules to sometimes an entire semester being devoted to SBIRT training. And this just shows you the breakdown of the different levels of education that our trainees had. We, in total, trained about 98 instructors, and that was the role that I often got to play. Together with Dave and Jeff, we were sort of the three musketeers that went around and did these trainings and prepared about 98 instructors to implement SBIRT. It was interesting, we did do a number of surveys, so as you came into the program, you completed a survey, and we collected baseline data that presented us with pretty compelling reasons for doing trainings in substance use disorder treatment. So 97% could not identify why drugs are hard to quit. 10% could not identify how marijuana is harmful to teens. About 82% identified e-cigarettes as safe. You can see the findings here. 52% viewed substance abuse as a habit, not as a disease. 53% viewed substance abuse as a form of wrongdoing. 30% believe people are oversympathetic regarding substance abusers. 31% believed money should be used sparingly to help substance use disorder patients. And almost 26% believed insurance plans should not cover people who misuse substances to the same degree they cover people with other conditions. I don't think it surprises anyone in this room that there's considerable amount of stigma that's imposed on our patients. And that's part of what I found exciting about doing the SBIRT trainings, is being able to offset that stigma and really emphasize the nature of this as a disease that warranted early identification and early intervention. So as Sherry mentioned, it did have that sort of smiley face kind of component to it,
Which is not bad.
where people rated they communicated their satisfaction with the training, and then they looked at the survey results post-training, 30 days later, and even 1 whole year later, and basically the satisfaction levels remained the same, and overall we had about a 71% level of high satisfaction, and then 22% were neutral, and then we had this population that was not satisfied, about 7%. We also looked at the increase in SBIRT knowledge using pre and post tests. We looked at the gains in knowledge about SBIRT that did reach a significant level in identifying screening tools, the strategies that comprise motivational interviewing, the qualities that make up a successful person, implementing motivational interviewing, and also being able to assess drinking risk in a patient scenario. Then we built into the training a chance to practice the skills, and then they were observed using motivational interviewing skills. And I thought it was interesting, even though over 90% of the students were quite confident that they were good at using the SBIRT skills after the core training, actually only 32% received a total passing score of 70% or higher. So going back to that perception issue, it was very interesting. And, if you watch somebody who's good at this, it looks very easy. And you just think, oh, I'll be really great at that. That's easily within my wheelhouse. And yet, it's surprisingly hard to be a really good listener and not to jump in with answers too quickly, but to let the patient come up with their own reasons for change and their own plans for change. We did score them using a standardized coding scale by D. Clemente, looking at their ability to raise a subject respectfully, and that was one of the strengths that our students had. They were required to review the current pattern of use among the students, to ask open-ended questions, and to use reflective listening. Some of the things they found most challenging was the ability to summarize the findings, to check back in with the patient, you know, this is my idea of the summary, does it match your idea of it? In providing relevant medical information, one thing about motivational interviewing, it has got a focus to it, it's got a directive element to it, and so it is appropriate to bring in medical knowledge. And that was a nuance that they were less likely to pick up on, that you can be somewhat directive. And they also kind of cut it short and failed to ask for or plan for a follow-up visit and follow-up treatment. Their perceptions of the utility of the training tended to be very high. And we would talk to our students about that. I mean, the self-reports that I heard matched the data in that they reported they could see themselves using these skills, honestly, not just with substance use disorder patients, but with patients with all kinds of medication adherence issues, obesity issues. Its relevance is really pretty broad. Some of the pushback we got, the negative feedback, was about this 5 hours of online training in these modules. So it was standardized, it was flexible, and it was boring. So that was not a favorite part of the training. We also found that the retention from the modules was pretty short term. If you didn't expect them to then act on what they learned within 10 days, it was gone. So also these modules did not translate into proficiency in using SBIRT. So that was a takeaway and feedback that we did provide to SAMHSA about that. So the baseline data that we got supports the need for addiction education. SBIRT knowledge can be successfully imparted at all levels using a mix of didactics, role play, and supervised practice. Overall satisfaction was positive. Face-to-face instruction is clearly preferred, with skill-based workshops most favored. Multiple supervised practice sessions were especially needed at the undergraduate nursing level. Our medical residents were a quicker study on learning these skills than the undergraduate nursing students. And overall, thankfully, the SBIRT training was viewed as useful. Thank you.